Welcome to this episode of the Biology of Trauma podcast. I'm your host, Dr. Aimie. I'm excited to share this conversation because it dives deep into one of the most overlooked root causes of a dysregulated nervous system, your own biochemistry. In this episode, we're exploring the 3 most common biochemical imbalances I have seen in those with trauma histories, addictions, and those adopted with attachment issues. These imbalances can create a biology of survival, making us more susceptible to experiencing overwhelm, emotional pain, and trauma responses. When I started my healing journey and was going to lots of different therapies, I was being held back in my progress, and part of the answer was that I had all 3 of these imbalances that we will talk about in this episode. Joining me is my friend and integrative medicine expert, Dr. Jason Loken, who is also trained by the Walsh Research Institute and incorporates nutritional solutions for these biochemical imbalances into his practice. You will learn how these imbalances can keep our bodies stuck in patterns of depression and anxiety, how they affect serotonin and dopamine, and the unique challenges faced by those with high copper levels, and why these imbalances often run in families. If you are a practitioner, health or mental health, mind or body, or someone on their own healing journey, you need to know these imbalances because they are more common than you think. Let's jump in.
So let's go into under-methylation, because we could talk about over-methylation, but so much of society is moving towards under-methylation. I feel like that would be a better focus of our time today. And with under-methylation, one of the challenges with that is its effect on the neurotransmitters, and specifically the serotonin and dopamine. And that leads to one of the symptoms being depression. And this is something that kids have. So this is something that is epigenetic. And so it's not an acquired disease that they get later on in life. And of course, one of the challenges that I present to the providers in my attachment and neurodevelopment module is the fact that, hey, these are even going to affect that healthy attachment bond between mom and the early child, because you need dopamine for that attachment to happen.
Yeah.
And you certainly need serotonin for the child to even feel well and healthy and happy and want to have that engagement with others. So walk us through your understanding of under-methylation and depression, and even then how would a person know that they might be an under-methylator, because they're going to be having other things other than just possibly. Not everybody has that low serotonin effect, but many do. And so, how would a person even know if this is something they should look into?
Well, I think the important part, like you said, is it's epigenetics. So part of that means that it's usually passed down family trees to some point. Usually you can even look through family trees and see, oh, Uncle Bob also seemed to be, depressed, or, really highly competitive, or something along these lines. You can see sort of some of these traits throughout family tree. And I remember Dr. Walsh saying methylation is established in utero between about week 1 and week 3. So you're born a lot of times with it, and it's literally sort of a part of your personality. And it doesn't necessarily mean that it has to be a problem. A lot of times with kids particularly, I'll sometimes explain to them it's kind of like a superpower in some ways. It just needs to be balanced out. Now, when that gets in its sweet spot where you kind of balance it out, I think you get all the benefits of it, but without the extremes that kind of pull people into imbalance and into ill health, where they run into problems with it. So methylation, Dr. Walsh would explain that about 70% of the population is normally methylated, about 22% under, and about 8% over methylated. And I think the key thing with what Dr. Walsh, and this is specific with, I would say, Dr. Walsh's research, as opposed to a lot of other researchers that do work on methylation. And I think ultimately it's good to see a large landscape, see where things land, because I think there's truths in lots of different stuff. But this was something that I found really valuable around methylation, specifically from the Walsh approach. And what he found was that a lot of under-methylators also had problems with the reuptake of serotonin and dopamine. So how I kind of explain this to patients, when we look at the biochemistry, there's sort of 3 big ways that I think that it can cause troubles. You either lack the key ingredients to make certain neurochemistry, or you've got excess or something that's causing an overconversion of one neurotransmitter to another, or you can't keep it in that gap between the two neurons in that synapse long enough to have the desired effect. Methylation affects how long it stays in that bucket, so to speak, between the two neurons. So what happens with under-methylators is methylation particularly has a bit more of a suppressive effect on genetics, right? So if you have particularly for this, there's a genetic that helps to make reuptake proteins. Reuptake proteins are basically like vacuums. They kind of suck up the serotonin and dopamine after it's been deposited or once it's been excreted out. So if you have too many of them, they don't stay very long. They get sucked up like a vacuum. Methylation, if you're under-methylated, affects that. You can't downregulate the gene that is making too many of these reuptake proteins. So you start to make too many of them. You've got too many vacuums. So even when you spit it out and it's supposed to sit there long enough to activate the next neuron, it all gets sucked up. So I kind of simplistically explain this to patients. It's like you've got a bucket and you've got a whole bunch of holes in your bucket. So even if you're making enough, it's all draining out. So you never get the benefits of that. So somehow you need to plug up those holes. Now, most of the time, people that are under-methylated may do well on specific medications to some point, like an SSRI type of medication, because it kind of plugs up the hole. But it's also not ultimately getting at the root of the problem, which is that we need to downregulate that gene that's causing the problems. Because as much as methylation affects reuptake neurotransmitters, we got to remember methylation is a big process. I mean, it affects things like energy production and mitochondrial function. It's a big player. Detoxification, huge. So it's like you don't just want to fix that little piece around the neurotransmitters. You ultimately want to fix the whole, and then the whole body, the whole system starts to become better. So that would be sort of the breakdown of how methylation affects things. Now, I would say some of the big symptoms when I'm talking to someone and they're like, oh yeah, check.
Right. Like
So,
I can recognize an under-methylation,
Yeah.
person from across the room now. Like it's
Absolutely.
so obvious to me because these traits are so characteristic. And I feel like that is one of the huge resources that Dr. Walsh has
I
given us
totally agreed.
is
Yeah.
being able to say, here are common traits. Not that someone's going to have all of them, but these are so common among people with under-methylators that you can use this as a guide to know if your system, again, like the whole system, not just the serotonin and dopamine, but the whole methylation
Yeah.
system is off balance.
I will often see people coming in and there's usually a little bit more of a type A-ness, I would say, to under-methylators in general, right?
And
They're
just be
not
careful, right? Because you are describing me here. So just remember that as you go into this description.
I'll try and sweeten it out a little bit.
That's right. Be gentle with your words. Be gentle.
And they would kind of traditionally be a little bit more strong-willed and maybe even a little bit more oppositional. And a lot of times you would hear that probably particularly the parents would describe that a lot of times. And so that's an example of something where, I've got two little girls. I've got a 4-year-old and one that just turned 6. So it's like, I want them to be strong-willed. I want them to have a certain degree of opposition and I want them to stay strong in their stance and know what's right, know what's wrong for them. So I think those are very important qualities. But if it gets, again, too stretched, there's no give. And then you end up just in this battle all the time with stuff. You get your feet stuck in the ground and it's like you're not budging, nothing goes anywhere, and it just creates a lot of confrontation. So I see that a lot with
it's no longer
parents and
serving
kids.
your best interest.
Right. You're just now in a constant sort of battle all the time. Under-methylators tend to be more likely to have seasonal allergies because methylation is inversely proportional to whole blood histamine. So if histamine's up, methylation is usually down. So one of the markers we might look at is a whole blood histamine to see where people are. That's not completely diagnostic. There's more pieces to that, but that was sort of one of the original tests that Dr. Walsh used. One that I think is probably one of the most stereotypical ones is competitive. I find that under-methylators they're not okay just playing a game most of the time. They really do want to win. And even if they've trained themselves to be okay, they know inside here that it kind of pisses them off when they don't win and it bugs them. So they definitely want to win.
The insights from an under-methylator, you have to go into the situation already talking to yourself, having that conversation in your head of, okay, Aimie, this is not about winning. This is about just having fun. I know this is hard, but this is just to have fun. You're not in this to win, right, Aimie? You're not in this to win.
And in the middle of it, you're having more conversations with Aimie to make
Yes,
sure
exactly.
that you remember our conversation earlier.
That's right. When it looks like I'm not going to win, I have to have that conversation.
I totally get that. Yeah. And also under-methylators can have a little bit more tendency towards sort of an obsessive compulsive tendencies, definitely controlling behavior. I think under-methylators like things kind of in a controllable way. And when that's sort of getting outside those boundaries of control, that starts to flip them out. And that's usually where you'll see a lot of kids will have a lot of like anxiety I'll see pop up when new situations are coming up. They're needing to kind of know lots of details around it. And even that often is not enough to kind of comfort them for it.
It's my understanding, Jason, that those who have a diagnosis of OCD, over 95% of them are undermethylators and really benefit from the types of protocols that you would give an undermethylator.
Yeah, I would totally agree with that. And
Mhm.
it just makes a lot of sense because you'll actually find that a lot of patients diagnosed with OCD have a lot of those other symptoms as well when you actually start to go in and explore it. And it is definitely one of the pieces that I really love because even in the Walsh approach, they will say, half of it is looking at the labs, the other half is looking at the symptoms. And if the symptoms are still there, even if the lab doesn't prove it, treat based on the symptoms. So, it's such an important part again, because what I love about it is it gets the practitioner. So it gets the practitioner to actually start to really do an in-depth intake. You really have to learn about the person, which I think in itself is really important part of the healing process. And it gives a lot of value to what science used to really be. It was really objective. You needed to kind of look at objective symptoms and whatnot and do, learn about it and observe it, right? It was observation. And what they've sort of found is through observation of thousands and thousands of patients over the years, they have found a lot of criteria that, like you said, aren't with everybody, but they show up with a lot of people. And a lot of times when people have it, they can check off some of the big ones.
Mhm. Yeah. So, can you share with people the two ways of testing undermethylation and kind of give them that guide of when you could use whole blood histamine and when you really should definitely use a methylation type of profile panel?
I kind of find now I always want to see the methylation panel because I feel like the whole blood histamine, and I actually had a consult with Dr. Walsh around this because there was actually a bit of a debate by another physician that does a lot of work with methylation and was kind of saying you cannot use whole blood histamine as a marker for methylation. And he had a number of reasons for that. And I actually had a consult with Dr. Walsh, asking him specifically around that. And he said, whole blood histamine was a really good marker that we were able to use initially. And because essentially to break down histamine requires SAMe, and SAMe is one of the main methyl donors. So essentially, if histamine was elevated, then it means usually you didn't have enough SAMe to break it down. If you had too much SAMe, too much methyl, then it would drop and you'd have very low histamine. So I often use that more to help me discern whether I think someone might even be over-methylated, because I think the histamine is a bit better marker for seeing if someone is over-methylated, whereas the doctor's data plasma methylation panel that we use is really a breakdown of the whole the majority of the methylation cycle. So you can see where is that person actually glitching somewhere in the cycle. And that always helps me because I've seen some patients where based on a whole blood histamine, we would then say, okay, well, let's give them SAMe, for example, let's build up their methyl. And they do okay, and then all of a sudden they don't do well, or they actually aggravate. And then you actually run a plasma methylation panel and you see, okay, well, they are low in SAMe, but they're actually high in the next precursor that goes from SAMe to SAW, and they're like this. And you want them ultimately be kind of in line. So if SAMe is low and SAW is high, if I add SAMe into the mix and they're having a hard time getting rid of SAW, all of a sudden this starts to build up and then creates even more undermethylation. So those types of nuances I think are really important to see because they cause you to then adjust the treatment more specifically for the individual. You might need to focus first on how do we start to assist SAW to come down rather than give them SAMe right off the bat.
And that's the same shift that I've been having in my practice, Jason, is that more and more that homocysteine level has become more important because it really helps inform the larger picture. And so it's not just looking at the SAMe. It's not just looking at histamine. It's not just looking at, hey, are you an under-methylator? Because if they are high in homocysteine, for example, starting them on SAMe is not the best first step. You've got to bring that homocysteine down first, or else you're going to be adjusting the methylation cycle and that whole system in ways that are not helpful in terms of their disease process.
Yeah, it's a really important point because it's again showing where not only could you be doing the wrong treatment, you might actually be causing harm in doing it. And the other thing that's really important to look at that is that if they're a strong under-methylator and they've got a lot of, say, depression, then also if you're aware of all of those things and then you're like, okay, well, they've got high homocysteine. So now I need to address the homocysteine. I mean, one of the first things people do with high homocysteine is give them lots of folates. And that could be an actual big problem because folates will have the opposite effect for the serotonin and dopamine, right? So you will actually cause a bigger drop of serotonin and dopamine. So you might start to fix the homocysteine, but you're going to cause them to go into possibly a much more severe state of depression or anxiety. So knowing those pieces helps you fine tune. It's like, okay, well, I'm going to give maybe more B6. Maybe I'll give some methyl B12, and maybe I'll give maybe TMG or something different to assist that process where I'm not going to do something that might actually cause some aggravation.
And this is where I see a lot of people going wrong with just I would say the most common understanding of methylation these days, which is where you can just do a genetic test, look at your MTHFR. And if you have a SNP in your MTHFR, then you should take methylfolate. And that is just such a simplistic view that, again, if you are an under-methylator and you're having that lower serotonin activity because of the reuptake changes, and then you bring in folate to that system, any form of folate, and you are actually driving that person worse into the serotonin imbalance and the depression. And so again, to your point where you could actually be doing harm just because you don't know better and don't know how to look at the methylation system in vivo, right? Like I don't care about the genetics. I mean, in the sense that they can help inform, but just kind of like the labs and the symptoms for the biochemical imbalances. I'm going to put more weight with symptoms than I am a lab test.
Yeah.
And same thing with the genetics. I'm going to put more weight in terms of, okay, but what are you experiencing in real life? And what is the result of this? What is the outcome of this? Let me look at the whole methylation system as it's playing out in your body, rather than looking at a gene and a SNP in a gene, which is kind of like looking at a test tube rather than looking at a living cell.
Yeah, I totally agree with you. And definitely sometimes I find the genetic SNPs can play into things. And again, it's this individuality. For some people, that just might be a really big deal for them and for the way that their whole body makeup works. But what I really appreciate about the Walsh testing is, and he did a good example of sort of describing, he said, there's thousands of different SNPs. So you could have a whole bunch that are actually over methylator SNPs and a whole bunch that are under methylator SNPs. And you've kind of got this tug of war going on between over and under methylation. So by looking at any one SNP doesn't tell you much of anything. You need to see how does the overall totality of it play out in the body. So this is what I like about testing that's more functional in basis. It's like, okay, so you got all these things. What's the end result? How's it actually showing up? And what do we need to then try to fine tune to figure out how to support it best?
We have about 5 minutes left, Jason. So in 5 minutes, I need you to explain copper excess, zinc deficiency, pyroluria. You can do that, right? You're good.
And go. I'll go through them quick.
These are really important though, because especially we mentioned the postpartum depression, and it's not just depression, it's postpartum anxiety as well. Certainly in extreme cases, postpartum psychosis. And it's so preventable if people understood some of the biochemistry behind it. So I'd love for you to share on the copper excess, zinc deficiency, and not only the postpartum effects, but certainly that. But then what are some of the other traits and symptoms that someone might have if they've got these?
So copper is a pretty common one. I think copper imbalance. So copper and zinc, like we had mentioned earlier, are teeter-totter nutrients. So when copper goes up, zinc tends to go down and vice versa. And what the Walsh Research Institute found, or what they found when they were testing a lot of this stuff, was that copper zinc imbalances were a big deal, and that people would start to find that they were out of balance and that you needed to have them really closer to like a one-to-one relationship for optimal brain function, or slightly more zinc to copper, 0.8 or 1 copper to zinc. And as soon as things started to go too high, particularly over like about 1.25, you start to run into a lot of troubles. If people have bipolar, he suggests to keep it below even 1.2. It can really be a trigger. So most of these things,
I think it was the trigger mostly because of the net effect on oxidative stress.
yeah, so high copper causes a lot of oxidative stress, as does elevated pyrols. And a lot of times, I remember him mentioning at one point around best test to check for oxidative stress. And he said pyrols and copper. If you see those two things, if they're out of balance, the person has oxidative load. So outside of looking at a bunch of these other testing for oxidative stress, a lot of times I just go back to that one. And so why that causes troubles is that copper is the main catalyst for a specific dopamine hydroxylase enzyme that converts converts dopamine into norepinephrine. So it's a reaction that goes on in our body. Everybody does this. But if you have too much free copper, it's literally driving that reaction. It's shunting it. So then what happens is you start to overconvert dopamine into norepinephrine. So inevitably, you're going to start to get lower amounts of dopamine, higher amounts of norepinephrine. So that can play out as dopamine's kind of our focus and concentration and seek pleasure to situations. That's going lower and lower and lower. And your norepinephrine, as much as it can be beneficial at a certain amount, too much, it's going to start to trigger that fight or flight, right? You're going to get that hyperactivity where we talk about attention deficit and hyperactivity. So I think they find that about 75% of children diagnosed with ADHD often have a copper zinc imbalance.
Say that again. I know I told you 5 minutes, so you're rushing through this, but like that right there is pretty significant.
Yeah, in the study
children?
in the study that the Walsh Research Institute did when they were looking at a bunch of children that were diagnosed with ADHD and oppositional defiant, a whole bunch of stuff, they broke down a bunch of the imbalances. But yeah, about 75% of the children had around ADHD had copper zinc imbalances. So it's a really important one to assess. And how it plays into postpartum is that during pregnancy, the mom copper levels often double because they're really important for neurogenesis in the child. So they need to come up. But if they have that epigenetic susceptibility where they can't drain off copper so easily then after they deliver, normally over the next few months, that copper should normalize, but it doesn't. It usually stays high. And I've seen some women with severe postpartum depression and their copper levels, optimally, you want around 10% free copper, and particularly no more than about 25% free copper. And I've had patients with postpartum depression closer to 50%, like really, really.
I've seen 45 to 50%.
Yeah. And what's going on is there's so much conversion that it's like, of course, it's just going to be an absolute mess. And I think why that's such an important one is because I find so many moms very much get told, you're just a new mom, you're just stressed, you're not sleeping. It's not that all of that stuff's not true, probably, but it's like, don't stop there. Don't stop there. I think that's the thing is like, even though stress plays into tons of stuff, but even if you are stressed, it will actually create physiological changes that usually need to be balanced to help that person get back out of stress. So something like this is like, I think that's a game changer. If anybody is dealing with postpartum, like go and get that stuff checked because it can absolutely make a huge difference.
I feel like stress is just kind of this catch-all. Let's blame everything on stress. And I want you to go manage your stress better.
Yeah, go. Here's a pamphlet.
Okay, right? Here's a pamphlet, or go find a counselor or a therapist. And there's just so much more behind this. And when you have high copper, there's no way you're going to be able to manage your stress because the copper is what's driving higher levels of adrenaline.
I explain it to people. It's like if someone told you to go and meditate or be mindful, but if you had a copper imbalance, it's like you just finished drinking 8 cups of coffee. So even if I went to go and try to sit, and I know that those are important things to do at some point, my body is doing this. And even the people that have done a lot of that kind of work have kind of been able to control it to some point, but it's never changed the way their body feels. So if you can change the way your body feels, then that will automatically change the thoughts that are going in the whole cascade that takes place from that point. So that's why I think checking the biochemistry can be so important, because if it's there, like you don't even know what your baseline's supposed to be yet. And you're fighting an uphill battle a lot of times.
Yeah. You're nicer to your patients. I take them to, I tell them to imagine that they're going to the zoo, right? Oh, awesome. You're going to the zoo and, such a wonderful place. And we're going to do some meditation there, maybe even some yoga. And we get to the zoo and I'm asking you to do meditation right next to the lion's cage that has no walls and no fence around it.
Yeah, exactly.
Your adrenaline is high and you're not going to be able to go there because that's not what your nervous system is paying attention to. It's paying attention to, is that lion going to come and eat me now?
Yeah. And if you correct this first, then you can go and incorporate those, and then you will get tons more benefit from doing them, because now you're in the right neurological state to benefit from it and to be able to even access what's required to make them work.
Yeah. I talk a lot about the word capacity. And it's like your nervous system is not even available and has the capacity to make these shifts of positive neuroplasticity as long as this is your biochemistry. It is literally keeping it stuck. So we got some work to do. We got some work to do. So
all right. Want me to run through
talk about
pyrals really quick?
Yeah.
All right.
Yeah.
So pyroluria. So pyrals are something that everybody makes. They're basically sort of a building block to making hemoglobin. They donate iron and then we pee them out. Everybody does that. If you have a epigenetic susceptibility where you make too many of them, then before you pee them out, they have a very strong affinity for aldehydes like B6 and zinc. So they sequester up a bunch of B6 and zinc, and then you pee it out, causing to be in a very severely deficient state of B6 and zinc. Why is B6 and zinc such a big deal? This is when I talked about how you can have one of the problems is that you can't make the neurotransmitters to begin with. So when you need zinc and B6 are major cofactors in the smooth running of a lot of different reactions in the body, particularly the ones that govern the last step, activating another amino acid decarboxylase enzyme that converts 5-HTP into serotonin, L-DOPA into dopamine, and glutamic acid into GABA. So if you do not have enough zinc and B6, you will run into a production issue. You cannot make them. And I find that people that have pyral issues are a mess. One of the first people I saw with pyral disorder, so you should be normal.
Right. I should be careful.
Right. So one of the first people that I actually diagnosed with it was my nephew. And my nephew had a lot of anxiety and a lot of learning issues and all of these things, but an incredibly sweet kid, really, really sweet disposition. And I checked him and he was actually an over-methylator with severely high pyrals, like almost the two most anxious that you can get. He would end up being under the table sometimes, like biting himself, just trying to like self-regulate. And I remember like checking his pyrals and they came back and he was almost at 100. And he was like around 96. And I remember just like, I just broke into tears. I'm like, oh my God, he was like 15 and he'd been dealing with this all of his life. And I remember phoning my sister. I'm just going, holy cow, like this is going to make a big, big impact. It took a little bit, but the thing I like about pyrals is pyrals almost always normalize. Whenever a Walsh practitioner gets elevated pyrals, we're excited because we know that that gets treated easily, usually within 6 to 8 weeks for a lot of people. I also saw a patient diagnosed with schizophrenia, whose pyrals were about 256, I believe, highest I'd ever seen. And I actually had a consult with Dr. Walsh, and he said, this is the patient that will probably be most likely to completely cure from it, because it's easier to cure from the pyrals than it is from some of the other methylation imbalances for schizophrenia. And last I had heard with him, we had gotten his pyrals right back down into a normal range, and he was actually working 2 different jobs and was not on medications at the time. So, these things are all in the realm of possibility, I think, if you find the big trigger. And ultimately, what I say to patients is it's not always to be off of medications. It's to find out what works and lets you have the biggest, best life. What makes you feel best? For some people, that's no medication. Sometimes that's a combination of things. It's individual for everybody, and it depends on the degree that the imbalances need to be addressed in that person and what they specifically need as we keep trying to unravel other parts of it.
Exactly. We're going for quality of life.
Yeah, absolutely.
Mm-hmm. Mm-hmm. And the pyroluria has been also really significant for the autoimmune population and being able to understand that there is this connection. I am working towards being able to create a dipstick test for cryptopyrroles so that we can use it as screening in schools.
Oh, I love that. I love that. Yeah, so important.
Early screening, prevention, and imagine all of the, I mean, for one, their own quality of life, even going through school and academics, but then the disease process for the rest of life, because it just will bring down that oxidative stress, slow that way down, and be able to prevent so many of the downstream effects of those high pyrroles.
Yeah, and I've seen an increase in pyrroles over
Yes.
this last couple of years
Yes.
because if you've got a susceptibility to it, stress will also cause you to raise your pyrroles, which will aggravate the stress even more. So if there's a susceptibility, then it opens the door to it to produce more. And because there's just been so much stress for people, I've seen, particularly with kids, I've seen so many kids coming through and that have pyrroles, and they also change during, we would often say like the terrible twos in teenagers, big body stress times where you're going through growth changes. So don't be surprised if sometimes the dose needs to change if you're treating a child and then they start to go through puberty and they aggravate because they might need a new dose of things.
Jason, thank you. Thank you. Thank
Oh,
you
you're
for
welcome.
sharing your expertise, your knowledge, and again, thank you for who you are in the world and what you're doing. It's an amazing contribution that you are giving to the world.
Likewise, Aimie. Thank you very much for having me on the show.
And thank you for tuning into this episode of the Biology of Trauma podcast. If you recognize any of these traits in yourself or a loved one or those that you help, remember that understanding the body's chemistry can be a game changer for the healing journey. Sometimes what we call personality traits or stress responses are actually just the biochemistry in action. If you would like to know more about these 3 biochemical imbalances, I have a guide and resources for you in the show notes. I will have a link to my guide on the 3 most common biochemical imbalances. These are the ones that I have seen in those I have helped with addiction, with stress, with trauma, with adoption. And it will have a list of the traits for each of them and how to get tested with my friends over at DHA Labs. I will also have a link to the Biology of Trauma book. At the time of this recording, you can join me in the Insider's Circle for monthly readings with me. There are also 2 related podcast episodes that I want to share with you. Episode number 7 was on identifying and treating copper excess for postpartum depression with Dr. William Walsh. And episode 90 was on Beyond Talk Therapy, addressing the biochemical basis of behavior with Dr. Robert Lustig. There are 2 related YouTube videos, a copper to zinc ratio YouTube video, as well as a video on Are You Predisposed to Trauma? Again, covering these biochemical imbalances. I am here to save you time and money by bringing you practical information that will help you accelerate the trauma healing journey. So please take a moment to subscribe, leave a review if you already have subscribed. Your reviews and feedback are how I make this podcast better, bring you great content, and help others find information that could change their life as well. I'm your host, Dr. Aimie. Until next episode, lots of love.